Hello, folks. Happy Thursday. Today is yet another. I feel like we're getting better and better and better at this. Another all CP solvers internal affair. And today I get to co-discuss with Yusuf, who I feel like is what it's defining accidentally or not, what it is to be a CP Solvers Academy member. Because I vividly remember my conversation with Yusuf for the first time a little over a year or so ago. I was actually in my favorite trail in San Francisco, and I have yet to tell Yusuf the story, but I was walking my dog, and in the middle of the conversation with Yusuf, I had to keep my cool because a wild dog or a coyote was approaching us, and I could only keep my cool and manage it because I didn't have to say much. Because Yusuf was on fire. He was so excited to share his love for clinical reasoning and so excited it was just ballooning with ideas. And so all I had to do was listen. And so I had to steer away my dog away from that, which was quite a stressful situation. But I think it's just so telling about what's happened with Yusuf since he's joined the academy, because I have, again, like I did in that moment, stayed largely silent, quietly hanging around in the background, watching Yusuf not just express his ideas, but actually bring them to reality. And he had very humble beginnings. He started like everybody who was in the academy knows. He was doing the bread and butter stuff that many of our recent members do, but has really shown us what it means to be a community builder, bringing so many people together over so many activities. And now, as I was jokingly saying to him, as he sits in his chair behind the high rise, that he is the CEO of something. And I think the truth is that he's essentially become the CEO of the Clinical Problem Solvers, officially being one of our co-directors of internal operations alongside Maddie and working with Jack. So I think it's quite the meteoric rise to where you are, Yusuf, and we're very excited to celebrate that in another way today. I'll hand the mic to you to say hi, and then we can introduce our amazing crew of other CP Solvers members who are partaking in today's VMR.
Thank you, Rabih, for your kind words. I remember first time talking to Rabih, I felt like I was talking to a celebrity. I was so nervous. I was listening to him on the podcast for like years, and then suddenly I'm talking to this person. I was like, oh my God, I'm talking to a celebrity. I hope today's case is not as scary as a coyote, but hopefully we'll be okay. But thank you for the kind introduction.
Oh, you're too kind, my friend. You're too kind. We have Julia scribing today. Julia, do you want to say hello?
Sure. Hello, everyone. My name is Julia, and I actually felt the very same way as Joseph when I first met you, and I'm just very happy to be in this space and excited for the case today.
Oh my gosh, I'm so glad it's dark outside. You guys can't see me blush as much. But yeah, I am no celebrity. I continue to have humble origins in my same old tiny office space, but I appreciate you both. We have two people who are working on scribing. Yuki's taking the lead with, of course, the supportive Parisa lurking in the background as per usual. Yuki, I'll hand the mic to you to say hello.
Hi everyone. Thank you for having me as a not presenter but teaching point. I'm really excited about this
And what time
and
is
the
it in
case.
Japan, Yuki?
Oh, sorry, could you say again?
What time is it in Japan right now?
Oh, now 10 p.m.
10 p.m. Oh my gosh. Okay. All righty. Thank you so
Okay,
much for doing this so late. Um,
thank you.
and I'll finally hand them back mic to Vinny, who is presenting his seventh case. Vinny, please tell us a little bit about yourself, and then we'll jump right into the case.
So, hi everybody. I'm Vini. I'm a medical student from Brazil. I'm very excited to present the case today. So, let's go. So,
All right. Yeah,
let's
whenever Julia shares the
start
screen, you're
with
good to
the.
go.
Okay. So, okay, for the first aliquot, we have a 51-year-old male who presents one day after a psychotic episode. A 51-year-old male was brought to the ED by his family following a psychotic episode that occurred at work. The patient, who works at an airport, unexpectedly removed all his clothes during the episode. His family reports that this behavior started one day ago. They deny any loss of consciousness, recent changes in behavior, mood, or functioning, and report no seizures, no headaches, any focal neurological deficits, no nausea or vomiting, or any gastrointestinal or urinary symptoms. The patient has no history of psychiatric disorders or prior episodes, no recent life stressors or any significant events, and has not started on any new medications. That's all for the first aliquot.
Oh my gosh, Vinny, this is so intriguing. Youssef, what thoughts are crossing your mind?
Yeah, in the initial aliquot, I see Vinny describes the patient's behavior as a psychotic episode, which is a very, very specific psychiatric term. Because if we're calling it a psychotic episode, that's in the psychiatric sense, we associate that with psychotic disorders such as schizophrenia, schizoaffective disorder, things like that. But if you think about it specifically, for example, schizophrenia, the mean age of presentation is 21 years old. And it's very abnormal for someone to have their first episode at the age of 50. But if we use analogic reasoning to call this like altered mental status or a form of encephalopathy, for example, this will broaden our thinking to, besides primary psychiatric disorders, to think of other causes of, could this be like a mimic, such as an ingestion, a withdrawal, or could this be a autoimmune phenomena, which is still too early to characterize. But I think when the word psychotic disorder, I immediately think of this is primary or secondary, and I'm trying to define the disorder. Is this an encephalopathy, or does this have any other like flavor, such as a deficit or a fever or any other flavor that I can attach to it as well? What are you thinking, Rabih?
Yeah, no, I think it's a really helpful conversation to have about what it means when we're given specific terms that could be somehow attached to an altered mental state. And so I'm curious, is your mind solving this in any way, shape, or form differently than trying to solve a case where Vinny had concealed the details and just said 51-year-old man presented to the ED after one day of altered mental status? And so if he had presented it that way, how do you think your mind would be solving it? And what are you extracting from the additional information about the nature of the altered mental state he's giving you?
Yeah, I think the shift in the prevalence of the etiologies shifts significantly by the description. Because if he told me, for example, an elderly gentleman presented for confusion for 5 days, I think even though I would be using the mnemonic, I would focus significantly on infection, delirium, and that's much, much, much more common. But here, because the description is more, it's like hyperacute for one day of encephalopathy, I'm thinking, oh, could this be more a medication related or a vascular event, which is less likely, but I would shift my causes of the etiology.
I'm right there with you. At the end of the day, I think this is the key sentence to upload in your mind as you're working to take care of patients with altered mental status is no matter what approach you use, what you're fundamentally trying to figure out is the problem intrinsically in the brain, or is the problem outside the brain causing referral issues to the brain? i.e., is this an intrinsic brain problem, or is this an extrinsic one? Examples of an intrinsic one would be that somebody has a brain tumor and that causes a seizure. Examples of an extrinsic one would be that somebody has hyponatremia and that makes them confused. Whenever we have focal neurological deficits, we recognize that there are some systemic extrinsic diseases that can do it, like hypoglycemia, but the majority of patients with an intrinsic, the majority of patients with a focal neurological deficit have an intrinsic cause of altered mental status. And so I guess the question, Youssef, is, are you calling this altered mental status without focality? Or do you have a sense that there might be some focality here? What do you think?
I think it's from the history alone, it's hard to say, but it sounds like there's no focal like neurologic deficits, but like Elena mentioned, like maybe there's affecting the frontal lobe potentially, but nothing like on I'm thinking less of vascular lesions, for example.
Yeah,
per se.
I think it's a nuanced conversation to now have between me and you about what it means to have a focal neurological deficit. What a focal neurological deficit fundamentally means is a disproportionate part of the brain is affected and the rest of it is spared. That's what it means. And so I think that in our overly simplistic internal medicine model, what we take to mean as a focal neurological deficit is the patient has focal motor or sensory abnormalities that break the symmetry. But I think if you think about it more, you realize that the brain is more complicated than just motor and sensory. For example, if this patient had come in with an aphasia, even though their motor and sensory is right, you would call that a focal neurological deficit. So the question is, does a patient who has a agitated psychotic features have focality? And the answer in most instances is yes. And the answer lies in diseases in the basal ganglia or in the frontal lobe. And so how does this then contrast with what we term as altered mental state? An altered mental status that internists use is probably more actually captured as a depressed mental state. So for the people for whom we're using MIST, metabolic infection structural toxin, what we're actually saying is they have a reduction in their level of arousal. And in patients who have a central neurological syndrome that isn't a reduction in arousal, it's often actually a focal neurological issue. And cortical and basal ganglia syndromes can easily slip under our radar as a diffuse reduction in arousal, but they actually represent a focal neurological lesion. And so examples of cortical issues that can fool us are visual phenomenon or visual field cuts that get missed, changes in personality or behavior from frontal lobe tumors, and as you're seeing here. So what my mind is doing is using the prominent agitated flavor here to suspect a basal ganglia syndrome more so than a frontal lobe syndrome, which has me worried about an intrinsic problem in the brain more so than I would have been worried if the patient had a reduction in level of arousal. As you said, the age of the patient strongly determines what that intrinsic disease is. So if this person were a 21-year-old with a prominent family history of schizophrenia, I would say that my suspicion for a microscopic disease at the level of neurotransmitters in the basal ganglia, otherwise known as schizophrenia, is the primary pathologic entity. But given the patient's age, we have to zoom out and consider other microscopic, structural, or substance-induced basal ganglia diseases. So you're not going to be looking for this patient having opiate intoxication as a cause of their altered mental status. You're going to be looking for extrinsic triggers that disproportionately affect the basal ganglia. And one example of them are all the dopaminergic medications that the patients can get or use illicitly, like cocaine or methamphetamine. So your evaluation is now, I think, centered around what are the extrinsic causes of basal ganglia syndromes, substances, medications, metabolic diseases. And if that's negative, then intrinsic causes, which can be structural or not. So I think it's actually very, very powerful to pay attention to the nature of the patient's altered mental state. And if it is anything but a depressed mental state, the probability of a focal, cortical, or basal ganglia syndrome becomes a little bit higher. And as a result, the shift occurs in the workup to think earlier than you would otherwise about intrinsic causes, and to alter your extrinsic workup to the structure involved and the extrinsic issues that might be at play. So I think it's so powerful to hear that this person is essentially like taking his clothes off in a public space. It's very, very different than most of the diffuse encephalopathy cases we see. I took more time just to try to shape our conversation for the rest of the time. So I'm curious if any questions arise from it or any clarification points for you, Youssef.
No, I like how you defined it even more narrower, and I think with a narrower differential diagnosis than just encephalopathy or altered mental status, and I think that helps a lot.
Alrighty, Vinny, tell us more.
All right, so perfect for the second aliquot, the past medical history. The patient has been out of regular medical care for several years, not using any kind of medications. The family history is not significant for any psychiatric disorders. In social history, the patient was born and raised in Brazil, has not traveled recently, owns a dog, is single, and lives with his mom. He identifies as a man who has sex with men, and the family is unaware of any substance abuse, alcohol, or tobacco use. For the physical exam, blood pressure fluctuates between normal and 150 over 100. Other vital signs are normal. About the neurological exam, the patient is alert and oriented to place, but not to time, and he appears confused and agitated. The patient alternated between periods of delirium and normal mental status. Short-term and long-term memory are intact in the moments the patient was not delirious. The patient had preserved fluency and comprehension, abstracted thinking and reasoning. Cranial nerves examination was normal. Coordination, muscle strength, and gait were normal. Normal deep tendon reflexes. Cerebellar function was normal. Pupillary responses, bladder and bowel function were normal. And the patient is just mildly dehydrated, and cardiac, pulmonary, abdominal, and extremity examinations are remarkable. That's all.
Any other incredible exam. Youssef, where are you at now?
Yeah, it sounds like in this case we don't have a lot of past medical history. We have maybe some social history, and we have maybe question mark some high-risk sexual behaviors. This upfront makes me want to think, oh, I want to know upfront if this patient is immunocompromised. I would want to screen for HIV, for example, upfront to know if they're immunocompromised. We see here that the patient is not febrile, although that does not preclude like an infectious cause. We could still be under differential. And then on the exam, we're trying to localize for frontal lobe, for example, versus basal ganglia lesions. In this case, we see most of the neuro exam is intact, except for orientation, some confusion, and agitation. But we see that the strength is intact, and otherwise we couldn't localize any lesions from that. So I think other than screening for immunocompromising conditions, I think my next pivot point would be, is this a mass lesion or a non-mass lesion that's affecting this patient? And then I think that would be my next pivot point to how to approach it further.
I love that division, Youssef. I think that's very, very wise. Is there a structural cause or not? And that's why the S is so important in altered mental status. It's very, very intriguing. And I'm curious what your take is on it, that Vinny is describing this patient oscillating. His blood pressure seems to be oscillating from normal to 150, and his status seems to be oscillating from confused and agitated to periods of normalcy. And so how are you factoring in the fact that this is going in a circle in some sense?
Yeah, I think things that are like intermittent come to mind. Things like a seizure that can be like having intermittent bursts come to mind, for example.
Yeah, I agree. I think that should be your reflex whenever you see somebody's oscillating mental status appearing over the order of a ER visit. And I think what you're essentially saying is that your next step is to visualize if there's a structural cause with imaging, and this observation that the mental status seems to be oscillating probably would have your neurology friends and colleagues having a lower threshold to do EEG monitoring in addition to that that imaging modality. I'm really curious, based on your instinct, do you suspect, I'll just ask it more professionally, what's your pretest probability of a structural cause based on what you know so far? Do you think that the imaging will be enlightening or not?
I think it's if there is a mass lesion, it's not big enough to compress any motor lesion and not big enough to compress any sensory lesion. So it would be either very small or no mass lesion, or very specific, very, very tiny, if any.
Yeah, I agree. I think the probability of for the basal ganglia to be affected in like this, it has to be symmetric in both sides. And so a mass would have to be exceedingly large. And without any headache or mass effect, I think would be pretty unusual. We might get some radiographic clues as to the cause. I think the interesting thing with regards to the blood pressure is to remember that the insular cortex and where autonomic control is very close to the basal ganglia. And so I think that is another potential localization syndrome of somebody who has potentially autonomic dysfunction, which is a feature of limbic diseases, which are right next to the basal ganglia. I think as we proceed towards imaging and towards EEG, it's really, really important to keep in mind that an encephalitis involving the limbic region could certainly be at play. And so as we proceed in a manner towards imaging and EEG for the reasons that Youssef articulated, the one thing not to miss in this situation is HSV. HSV presenting as a limbic encephalitis. So for me, I'm a little bit nervous because we haven't found any other explanation for, and sorry, we haven't found any systemic fingerprint of this disease. And so as we proceed to rule out a structural cause or a seizure, that'll happen, I think, fairly quickly. I think it'll be really important, unless we find anything, to prioritize of the many things this could be, a very treatable infection. And to remember that HSV encephalitis affects people of all ages, including a 51-year-old man. So this is going to be a tense initial hour or two in the emergency room. Youssef, I'm curious to lean in on your experience about what pearls or tips you have for people listening to this about how you work with this patient and your nursing colleagues and other people assisting you at the bedside to manage somebody who might be agitated. And what tips have you accumulated from residency and early attendinghood about? It's a very tricky scenario.
Yeah, I think when considering if a patient is agitated, the question is, why is this an issue? Is this a patient safety issue? Or is this a staff safety issue? Or is this just, we just want to treat the condition? Because in a lot of cases, a lot of studies show that there's no benefit of using antipsychotics to treat agitation. They actually might have on the long term some mortality effect if we keep sedating patients with antipsychotic medications. for no obvious reason. So in themselves, antipsychotic medications are not beneficial unless you're treating a primary psychiatric disorder. But in other conditions, I would consider patient safety and staff safety, because sometimes you might have to use these medications or physical restraints to help to ensure safety. But otherwise, I would try the things that help the most are having family members around, frequent reorientation, having exposure to sunlight and visual stimulation, auditory stimulation, and things like that, and avoiding any form of restraint unless there is physical harm to the patient, to themselves, that they're trying to pull like their IV lines or hurting themselves or others.
Yeah, I completely agree with you. I think the risk-benefit ratio of using antipsychotics and physical restraints is a very, very nuanced one. And the benefits will only start to match the risks when the patient has exhausted all other options. And so I think it's very, very important not to expose the patients to pharmacological medications unless your indications are that there is an emergency here. And that emergency may be that there is physical harm to anybody, or that the patient has not had any success in any other modality, and this continues to pose a risk of high risk of harm to somebody else. So really trying to avoid these medications and not to use them for convenience is really key. All righty, Vinny, let us know what you have next.
All right, so for the third aliquot about initial labs, CBC and CMP completely normal, DRP normal, and HIV test positive. So it is important to mention that at the first moment that the medical team talked with the patient and wasn't able to take like a good medical history and understand the situation better, was just the family that was giving all the information. And later, when the patient was more calm, he revealed that he has known about the HIV positive status for 8 months, but had not informed his family and has not received any treatment. And also, CD4 count is 194 with a viral load of 142,000. Endoscopy was performed and revealed Candida esophagitis. Sputum test negative for tuberculosis, and syphilis also negative. That's it.
Thank you so much, Vinny. Very, very important twist. Youssef, you were hoping for an HIV test and it has come back positive. How has it influenced your thinking now?
Yeah, I think in general, when I hear about the diagnosis of HIV, I would want to know the CD4 count. The CD4 count is actually affected in the acute setting, in the setting of infections or inflammation. It might be suppressed. So it is not a reliable number. Like in this case, we see a CD4 count of 194, but we don't know if the patient's actual CD4 count is 194. A lot of times we check the CD4 percentage. That can help. However, in this case, we also see a case of candida esophagitis. So that confirms our suspicion that the patient's actually CD4 count is actually low. So that's just initially, I would try to stratify the patient's degree of immunosuppression. And then in terms of the quality of immunosuppression, I think we know that with CD4 counts that are low, affects the T cell immunity of the patient. And this usually leads to susceptibility to a lot of subacute mycobacterial infections and then viral syndromes as well. And then if we overlap HIV with CNS, then there's a lot of, although we think of HIV as a susceptibility to infections, this also causes a susceptibility to malignancy, because first of all, like the viral infections can incorporate into the DNA. This can cause alteration in the tumor markers, and this can cause tumors. And then the proliferation of infections like EBV can also cause tumors. So my next pivot point would also still be is this a non-space occupying lesion or is this a space occupying lesion? I think the patient, our pretest probability of space occupying lesion is low, but I think if we're headed towards an LP, which is one of the criteria is immunocompromise, we would want to know if there is a mass lesion. And I think we are narrow enough to start considering differential diagnoses. If we're considering non-space occupying lesions, we think of things like PML or CMV or even HIV encephalitis. Encephalopathy itself can cause it. There's an entity called CD8 encephalitis as well. And then the common things being common, HSV is still very, very at play here. It's a very prevalent infection. And other viruses and syphilis as well. I think the serum syphilis testing was negative here, but we would still want to double check that. And then if we see a brain lesion, then I think that would also change the diagnosis. But I think we can talk about the differential if that comes up.
Gosh, you're on fire. That was absolutely amazing. I think I am right there with you. I appreciate you applying the nuances of the CD4 count. And I think it's helpful whenever a test is not reliable to clarify in what direction is it not reliable. And so the CD4 count is artificially suppressed in the acute setting. And so you know with a high degree of confidence that this person's CD4 count is greater than or equal to 194. And so it is unreliable, but it's only unreliable in one direction. It's not like it's a chaotic test that can oscillate. And so it's actually helpful here to know that the CD4 count is either 194 or higher. And I think that influences our analysis, our pretest probability of all the infections that are at play, because while there's a wide range of vulnerability and the strict criteria we learned in medical school at 50, 100, 150, and 200 are not rigid parameters, it gives you a flavor of what your pretest probability is here. So a CD4 percentage is a way better test, but it illustrates the concept that in acute processes, when somebody is in the hospital, everyone's lymphocyte count goes down, but it doesn't go up. And so that's why the CD4 count here of 194, almost 200, exposes the patient to the finding of Candida, but may lower the pretest probability of CMV, toxoplasmosis, so on and so forth, but lower, not eliminate. And so I think that you're on the hunt for like, what kind of conditions occur in patients with HIV with a relatively preserved CD4 count. And you can start to think creatively about how that might influence your workup, but you should never lock in that this can't be toxo, crypto, or CMV. I just think that it's helpful to have a conversation about how blood tests can be really, really helpful in this scenario, because oftentimes there is this pressure to get CSF fluid, but there are a few blood tests here that would be very, very beneficial. I think the most beneficial blood test we already have, which is a negative syphilis serology, the rule out of that is very high. But I'm curious, Youssef, can you think of any blood tests you think that might really shift the calculus? A simple, easy blood analysis that you might get in patients with HIV?
I think a serum cryptococcal antigen is very specific and a good sensitive test as well, and will significantly alter the management and has like a rapid turnover. An RPR as well. If it's positive, it would immediately change our thought process as well. I think these are like low-hanging fruits, I think.
Yeah, I completely agree with you. I think the CRAG has revolutionized, well, at least my approach to these cases. Of course, there are situations where it's not perfectly reliable, but I think the prozone phenomenon, other circumstances, but I think it's a great test. And RPR is another great test. In this specific instance, the moment you utter toxo, you can invest in the value of a toxo IgG. Almost all toxoplasmosis disease in patients with HIV is reactivation of toxoplasmosis. And so the patient has the bug and it gets reactivated. So if you get a toxo IgG and the patient is negative, the probability of toxoplasmosis CNS disease drops significantly. And so a negative toxo IgG here would almost eliminate the possibility of toxoplasmosis. And so that's another thing you can keep in your back pocket. Another test that comes up for patients with HIV in general is the AFB in the blood, AFB blood culture. That's a really decent test for disseminated Mycobacterium avium intracellularly. That is not an infection that behaves in the manner that we're seeing today. But just to arm you with really helpful blood tests to consider for patients in HIV, I think the RPR and the crypto are probably the most helpful. And then you'll see instances where the AFB blood culture and the toxo IgG also be helpful. Most of these, a hodgepodge of these tests and other tests like baseline resistance sequencing, certain HLA haplotypes to ensure there's no drug-drug interactions. You'll see that done by our HIV ID experts for most patients who come in with HIV. And so this is just a snapshot of what kind of infection. So here, I think you probably invest heavily in a cryptococcal antigen, and you might invest in a toxo IgG, though that investment may be not productive if you learn that the patient does not have a structural cause in their brain. So, I think it's probably helpful, Youssef, since we've talked so much, to kind of summarize where you're at with what you're calling this problem to help us gain clarity next. So what now that we have it crystallized, what would be your mental summary of this case so far?
I think the way I would phrase it is a 51-year-old gentleman with history of untreated HIV presenting for likely meningoencephalitis.
Awesome. Love it. All right, Vinny, let us know what you got.
One question. I don't know if this isn't even possible, but how do you interpret if you ask for the CSF and comes like, for example, positive or negative cryptococcal, and it is distinct from the blood antigen or serology about the cryptococcal? Yeah? For example, if you have like a blood cryptococcal positive and negative CSF, could be like disseminated, or how do you interpret?
Yeah, Youssef, what's your take on this?
I think based on what I've read is that every test has a sensitivity and a specificity. The peripheral serum crypto is usually sensitive and specific, but you will have cases where the serum is negative and then you can still have the CSF be positive. In this case, you would treat it like a true infection. I don't think I've seen the opposite. I don't know about the test characteristics of the CNS. Usually the CNS testing is usually less sensitive than as well. So I'm not sure of sensitivity and specificity of the CNS crypto.
Yeah, I don't have expertise in this domain, not even close. And so I will just tell you that there's two principles at play here. Whenever you get discordant results, you really have to apply the principle of the performance characteristics of the tests, but also ask yourself two questions. What was your pre-test probability of this disease in the first place? And if it was high, you'll probably lean on assuming that the test misled you, and if it in fact did. And then the other is, what is the morbidity of the diseases you're considering? And so I think that that is probably what one would do in vacuum, is you would, in a morbid disease like Cryptococcus, if your pretest probability was pretty high, I think you would lean to interpret the test in a way that suggests that the disease is present. But in these instances, we often reach out to our experts, our expert ID colleagues, to help us. So I don't know the answer to that, but I think the principles to help interpret it are: what was the pretest probability of the disease? What are the test characteristics? And what is the morbidity of the disease? But our experts often know much more about the test characteristics than we do.
All right, perfect. So amazing discussion. I have two more aliquots. And for the fourth aliquot, a CT scan of the brain was performed, and the scan shows lobulated hyperenhancement in the right frontal parietal region with leptomeningeo enhancement, vasogenic edema, and sulcal effacement. There is also a large cluster of small, homogeneously enhancing nodules at the high right parietal convexity. with mild thickening of the overlying dura suggested. So the conclusion is that we cannot conclude about any specific lesion that points to an etiology. We can just point that there is an inflammatory signs in the brain. That's it. I'm sorry, I'll continue the CSF analysis. The cell count, 80 cells with 97% lymphocytes, protein 172, glucose of 31, lactate of 22, adenosine deaminase was normal, 3.5, rapid molecular test for tuberculosis also negative, PCR for JC virus negative, PCR for Cryptococcus negative, beta T glucan negative, and also toxo IgG negative. And I also would like to ask to you guys in the chat what additional tests you want to ask.
Vinny, this is very, very intriguing. Yeah, Youssef, what happened in your mind?
I think the syndrome has narrowed significantly. So I think that how I would name the syndrome is a patient with lymphocytic pleocytosis and leptomeningeal enhancement. And I'm trying to think of the overlap between the two schemas of these two. Because with lymphocytic pleocytosis, I consider viral syndromes and mycobacterial syndromes, rarely syphilis and tick-borne diseases. Other things to consider are fungal infections and lymphoma, amongst others. Out of these etiologies, the things that can involve the leptomeninges definitely include fungal organisms, TB, which is usually more subacute, but can present this way, and then the lymphoma, which patients with HIV are susceptible to. And I think we also had a case of neurocystocercosis, which was similar, but of course that is exceedingly rare to the parasitic infections as well.
No, Youssef, this is outstanding. I think you are, whether or not you get official training, you're a budding infectious disease and maybe an hem-onc enthusiast. I think just to follow up on the point we were talking about, I think that the syndrome is now clear both in terms of who the patient is. This is a vulnerable patient with the immunocompromising condition like HIV. But also now I think the frontoparietal region is probably the explanatory issue for what we saw in the airport and what we're seeing now. And I think because you have vasogenic edema, the probability of this person having both a meningeal syndrome and a brain mass with smaller nodules is very likely. So in some sense, this person has disease in two different compartments of their brain. He has a parenchymal disease evidenced by the frontoparietal mass, but also has meningeal disease. So whenever you hear HIV plus brain mass, there's two diagnoses that are often the tension of many care providers around the world, which is this CNS toxoplasmosis and is this primary CNS lymphoma? That's the center stage of the vast majority of the conversations whenever you have an isolated brain mass. That's because many of the other things that cause brain mass as metastatic tumor or metastatic infections often leave an imprint below the neck on the patient. And so I think it's very important to emphasize in our problem representation that this person has isolated meningoencephalitis, but we don't quite know what his CT of his chest or abdomen would show. But since he hasn't given a signal below the neck, I think our operating hypothesis will be that this process is isolated to the brain. And so that helps us make tremendous progress. And again, it reinforces the notion that toxo and a brain mass are often the things we're thinking about. And so here, this case shows you the value of a toxo IgG. The negative predictive value of a toxo IgG is extremely high. And so your operating hypothesis would be that toxoplasmosis is made much less likely. What that does for you is it pushes you to either proceed towards getting cytology from the LP, which often is very low yield for CNS lymphoma, but pushes you closer and closer and closer to needing a brain biopsy. So again, isolated brain mass in a patient with HIV, toxoplasmosis, CNS lymphoma as the tension point. What happens in most cases? In most cases, you're not really sure. And so sometimes you empirically treat for toxo and proceed down the algorithm. Here, we would not empirically treat for toxo because the toxo IgG is negative. So we proceed down the algorithm. And one path of the algorithm is to realize that in most of these instances, tissue is the issue and a brain biopsy is needed to diagnose a CNS lymphoma unless the cytology from the CSF is positive, or you have another space-occupying infectious process. And the notorious mimickers, there are three of them: Cryptococcus, tuberculosis, and in Brazil, Chagas disease, trypanosomiasis cruzi. So I think it would be a really interesting analysis to say, how would we move forward? I think that the fact that this person has a negative cryptococcal in the CSF is good, but I think we would probably need a serum cryptococcal antigen to make sure that this patient doesn't have a primary parenchymal cryptococcoma located in his brain, and that his CSF is negative because the meningeal component isn't very powerful or very robust. I think that the default hypothesis in most cases would be to pivot towards CNS lymphoma in a patient who has a preserved CD4 count, but I think it is relatively unusual for a primary CNS lymphoma, which lives in the brain, to have such a prominent leptomeningeal fingerprint as evidenced by the degree of lymphocytosis, but most alarmingly, by the degree of hypoglycemia, relative hypoglycemia in the CSF. Most cases of primary CNS lymphoma, the disease is restricted to the brain parenchyma and is often not found in such a high level in the CSF, causing the commonly disappointing scenario where you sample the CSF, you make no progress. The one test you could consider is an EBV PCR, though its performance characteristics are questionable. So I would summarize our thinking to say that toxo has been eliminated, CNS lymphoma starts to take up more space, but the arguments against CNS lymphoma here are the degree of lymphocytic pleocytosis in the CSF and the degree of hypoglycemia, which would be in keeping with the leptomeningeal lymphoma, which is uncommon in a primary CNS brain lymphoma. And so my gaze would be averted to Cryptococcus. My gaze would be averted to tuberculosis despite the negative testing. And of course, Chagas disease, though Chagas usually occurs in patients with a lower CD4 count. So that's where I would be at. I would be getting a serum cryptococcal antigen. I would be potentially getting more CSF for AFB, getting an EV PCR, and knowing that the ultimate goal here is to try to see if we can get a diagnosis without a brain biopsy. The performance characteristics of a brain biopsy are exceptional and allow us to diagnose these conditions with very little morbidity and mortality and under the expert hands of a neurosurgeon getting it. But I've spoken a lot, Youssef. I'm curious where your head is at. Any other thoughts that have come to your mind before we hear from you?
I think the thing we didn't mention was the most common cause as well of like space occupying regions, like a bacterial infection, is also very common, but usually doesn't cause leptomeningeal disease. But in all comers, we need to think of that. The other thing is I'm thinking of is what will we do right now? Like if some of the tests will take time. So I think to put our nickel down, I would try to get chest imaging as well. If we have like multiple nodules, if we have many lesions that are suspicious for TB, I would start like potentially empiric treatment, obviously with the help of infectious disease. And then one of the few conditions that we don't start antiretroviral therapy in patients with HIV include cryptococcal disease and TB. So in this case, we're at a point where I would start empiric meningoencephalitis coverage, potentially start acyclovir, get chest imaging, and then if the suspicion is high enough, we could empirically start right therapy. But I think that it will depend on how quickly the tests will come back. And then if the tests come back negative or positive, because the pretest probability is so high, and the morbidity is also high, this is a scenario where we might consider discussing initiating therapy as well. And then Vinny asked about the serum quant, like would we get a quant? A serum quant is similar to an IgG. Like, would you get an IgG to HSV? It only helps you, that tells you that the patient has been exposed. If the IgG is negative, it also, the patient could still be exposed to it, but the test is negative. So if it's positive, it's helpful, but if it's negative, it's not helpful. And if it's positive, it doesn't tell you if there's an active disease. It just tells you that the patient has been exposed. So I think if the tests are taking time and the quant is positive, it might push you to start empiric therapy, but it doesn't tell you that there is an infection or not necessarily.
Oh, yes, amazing. Don't even know what to say. So for the last aliquot, a test called lateral flow test for lipoarabinomannan came positive. So the final diagnosis is neurotuberculosis. I'll talk briefly about the management plan and after pass the word to you guys. And initially, empiric treatment for tuberculosis following the negative cryptococcal PCR and the lymphocyte predominant CSF findings was made. And also corticosteroids, the RIP therapy schema was initiated. Also acyclovir ampicillin for possible listeria infection. Fluconazole for the candida, esophagitis, and also valproic acid. And after the treatment, the patient improved clinically despite fluctuating cognition and altered mental status. And the antiretroviral therapy was found due to acute infection. So Youssef, you was right on target.
Amazing case, Vinny. Youssef, how are you digesting this?
I think this is an amazing case, and unfortunately, just prevalence-wise, TB is one of the most common infections worldwide. There's like a staggering number of infections yearly, and it's very, very prevalent. The testing is hard to get, and we still don't have the technology to detect it quickly. Like AFB take weeks to come back. TB PCR is hard to get, so the molecular testing is still getting updated worldwide, and it's expensive to test for it. I know this has been like a campaign, especially this year and last year, to get testing, like gene expert testing, to become cheaper, so everybody has accessible diagnosis promptly, but this is still not prevalent worldwide. And if we just talk about it like prevalence-wise, this is exceedingly common, unfortunately. Even though it takes years to show up, it's very, very common. And I have to expand. I can't wait to read more and expand my illness script on leptomeningeal disease and causes of leptomeningeal disease plus brain lesions.
Yeah, there's a lot of learning to be had in this case, and I think it was just ultimately base rate really supersedes almost everything else, and the way you can really reconcile everything in simple ways is the toxo IgG rules out toxo. The degree of lymphocytic pleocytosis and hypoglycemia rules out essentially primary CNS lymphoma. The degree of immunocompromise is not sufficient for cryptococcus in most instances. Oh, by the way, Julia, I think we're seeing your, just so you know. And so I think that's where TB sneaks in. It can occur in patients with HIV at any CD4 count, and it is the one infection that bridges the brain parenchyma and the leptomeninges very well. Cryptococcus loves the meninges, can go to the parenchyma. Toxoplasmosis is the opposite. It loves the parenchyma and can go to the meninges. But TB is a hungry monster for both, and I think this case really illustrates that. And when you factor in that the person's CD4 count is greater than or equal to 194, it becomes a very likely consideration. So yeah, I'm curious, Vinny, tell us, I know you had some teaching points prepared beforehand. Tell us what happened. How did the patient do if you know that information? And yeah, we'll go from there.
Yeah, okay. So I've prepared some key teaching points, and I would like to begin by discussing why narrow TB was suspected initially. And the first step that I want to discuss is about tuberculosis and HIV co-infection. First, let's talk about the significant link between the tuberculosis and the HIV. Mycobacterium tuberculosis is the leading cause of death worldwide among people living with HIV. The risk of developing active TB in HIV positive individuals is approximately 30 times higher than in those without HIV. The second point is about the global burden. The World Health Organization highlights the severity of the disease with 3 lists of 30 countries each. The first one identifies countries with a high burden of TB. The second one identifies countries with TB, HIV co-infection. And the third is about countries with multi-drug-resistant TB. These high-burden countries are prioritized for global TB control reforms due to their significant number of cases and their substantial impact in public health. The third topic is about methods to diagnose TB. And when it comes to diagnosing TB, the gold standard, as we know, is the culture of the Mycobacterium tuberculosis. But this method is it is an excellent method. It's highly sensitive and specific, and it allows for drug susceptibility tests. However, this method is time-consuming, often taking weeks to yield some results. So to accelerate the diagnosis, rapid molecular tests like the Gene Expert and MTV are utilized to detect TB and drug resistance more quickly. Nucleic acid amplification tests also offer rapid, accurate results. While sputum smear microscopy is a faster method, it is less sensitive and primarily used in research limited settings. It is important to note that asking for a quantiferon assay in this context, as Youssef mentioned, it wouldn't be appropriate. They are just designed to detect latent TB and rely on immune system ability to produce the interferon gamma in response to the TB antigens. So in a patient with a TB and significant immunosuppression, like the one we have, the reliability of the test is compromised, potentially leading to false negative results. And finally, the last point that I want to make is the role of the LF-LAM in the diagnosis and management. So now let's focus on the LF-LAM test. And it is a valuable point of care too, particularly in people living with HIV who have advanced immunosuppression. It's easy of use in various clinical settings, whether in hospitals or outpatient clinics. It makes it very effective for initiating timely TB treatment. It's a urine test, and however, it is important to remember that if you have a negative LF-LAM, does not result, does not rule out active TB. So further evaluation and testing are necessary. You don't need to stop here. You need to continue to pursue due to the high prevalence. So finally, to ensure an accurate diagnosis and to guide treatment, additional tests like the rapid molecular tests, the TRM-TB, and culture should be done, and it's very crucial. Yeah, so that's all, guys. Thank you for the case.
Really, that was amazing. Oh my gosh, I thought Youssef was a TB expert, but I feel like you are up and coming, and I can easily imagine you in a short period of time having a discussion on par with the one and only Youssef. Before we hand the mic to Yuki for her teaching points, any final reflections or thing you wanted to share, Youssef?
No, I think just thank you so much, Vinny, for bringing this amazing case and of a common presentation of a common disease. And I think it helped us think about like immunosuppression in general, diseases in patients who are immunocompromised, and CNS disease. So thank you.
Alrighty, take it away, Yuki.
Hi, thank you for your fantastic case. And then I really, really appreciate really great discussion, like as always, from Dr. Rabih and then Dr. Youssef. Thank you so much. I really learned a lot about HIV and then TB. And today's case was 51-year-old male with psychotic episode. When we encounter patients with psychotic episodes, we need to think about a mimicker, or it's gonna be a mimicker of autoimmune disease or infection or delirium. And regarding schizophrenia, its mean age of presentation is 21 years old, and many patients tend to have family history. So this patient does not have any family history of schizophrenia, and then considering his age, schizophrenia, the possibility of schizophrenia is not high, but we need to also think about this. Psychotic episodes can be reworded like altered mental status. So when we thinking about altered mental status, we need to think about it's intrinsic or extrinsic. So intrinsic factor is like brain tumor, seizure, and the extrinsic factor is kind of a hyponatremia or hypoglycemia. And altered mental status can be differentiated like with focal deficits or without focal deficits. So focal neurological deficits can raise suspicion of part of brain affected, like focal motor sensory damage or focal sensory damage. And altered mental status also can be think like agitated behavior. Agitated behavior patients had think frontal lobe syndrome. And basal ganglia also it control motor function. So agitated behavior can be a thing like basal ganglia syndrome. So basal ganglia, when we think about basal ganglia syndrome, we need to consider it can be structural or substantial or medication or metabolic. Because disruption of the cortical circuits leading to altered mental status. And concerning sexual behavior, medically concerning sexual behavior, we need to raise suspicion of HIV. This patient had an oscillating mental status, so we need to differentiate seizure, encephalitis involving limbs. And if we encounter agitating patient, we need to consider, is that the issue related to patient safety or provider safety issue or medical issue. And we sometimes use antipsychotic medications to control agitated patients, but it's reported that antipsychotic medications are beneficial only for primary psychosis patients. So we need to be careful when we think about indication for antipsychotic medications. And this patient had a positive HIV test, and when we see HIV patient, yeah, we always value the count of CD4, but in acute infection, a CD4 count is not reliable. So in that case, we need to check a CD4% because it's really helpful even in acute infection. And low CD4 count increases risk for mycobacterial and viral infection, and it can also increase susceptibility for malignancy. This patient had HIV with psychosis, so we need to look for imaging tests because it can be differentiated like space occupying, most commonly bacterial, versus non-space occupying causes like HSV encephalitis, CMV, HIV encephalitis. And when we do blood tests in HIV patients, serum coccal, PR, toxo HIV, and AFV culture is really, really important. And if we get kind of discordant result, we need to think about the previous probability of the disease and its mobility of the disease. And this patient had lymphomeningeal enhancement. This patient was immunocompromised. So in this case, we need to raise suspicion of tuberculosis, fungal, and lymphoma. And HIV patient with isolated brain mass, CNS schizoprosmosis versus primary CNS lymphoma needs to be considered. And brain biopsy is a really, really important investigation unless high suspicious for cryptococcal, TB, and Chagas disease. And if we search initial therapy based on patient's situation, chest imaging to look for tuberculosis is necessary. And regarding tuberculosis, it is still the most common infection worldwide, although diagnostic tests will take a time. And this patient had TB, tuberculosis, HIV co-infection. This is the leading cause of death worldwide among patients with HIV, unfortunately. And if, as you know, tuberculosis needs some time to diagnosis because culture, TB culture is the gold standard. But now we have NAAT. It can offer quick, accurate results. And we also have another option. We call it LFLAM test. It's really valuable as a point of care tool for patients with advanced HIV because it's effective for initiating tuberculosis treatment. But we need to be careful because it doesn't rule out active tuberculosis. Thank you so much.
Thank you, Yuki. That was amazing. Every single point that was made and more. Thank you so much for walking us through that sequentially and absorbing both Youssef, mine, and Vinny's teaching points at the end. That was awesome. All right, guys, I hope you have a wonderful rest of your day and look forward to seeing some of you guys tomorrow for RLR. It's a special treat because our beloved Rabih is coming back and presenting a case. He hasn't presented a case on RLR in a minute, so I think it'll be, I'm getting nervous already, and as is Yusuf's cat, maybe. Bye.